Okay, so hi everyone. Today we're going to be talking about intraparenchymal hemorrhage. Okay, now coming to the causes, the number one cause is going to be hypertension. So hypertension is the most common cause of primary intraparenchymal hemorrhage. Okay, then we have trauma, coagulopathy, certain sympathomimetic drugs like cocaine and methamphetamine, then cerebral amyloidangiopathy. Okay, so this is a very important cause of lobar hemorrhage in the elderly population. Okay, in the elderly population. Then we have AV malformations, brain tumors, especially metastatic brain tumors. Okay, so there are certain primary tumors which have a propensity to cause hemorrhagic metastatic brain lesions. So we'll discuss about that in a while. Then hemorrhagic transformation of an infarction. So around 1 to 6% of ischemic strokes will go in for hemorrhagic change, okay, especially large infarctions, and hemorrhagic transformation most commonly occurs in basal ganglia, the cortex, and the subcortical regions, okay, and the subcortical regions. And then we have a rare cause of intraparenchymal hemorrhage, that is capillary telangiectasias. So this commonly is going to occur in the brainstem. So capillary telangiectasias commonly occur in the brainstem. This is an important MCQ question, okay. Next, coming to a short discussion on the epidemiology, 10% of all strokes are going to be hemorrhagic. Most common is ischemic stroke, 90% to 80 to 90% is ischemic stroke. Okay, the second most common, or 10% of all strokes, is going to be hemorrhagic stroke. Okay, but remember, hemorrhagic strokes have a very high mortality. 35 to 45% is a mortality in the first month. And the incidence is higher in Asians and Africans, and in Asians especially, the incidence is high in Japan. And two important risk factors are advanced age and heavy alcoholism. Both of these are going to increase the risk of intraparenchymal hemorrhage. Next, coming to the most important or most common cause of ICH, that is hypertension. So hypertensive ICH occurs due to rupture of small penetrating vessels, okay, which have a diameter of around 30 to 100 micrometers. This is an important MCQ. So what happens in this vessel is, number one, we are going to have segmental lipohyalinosis. Okay, we're going to have segmental lipohyalinosis, and number two, we're going to have microaneurysms. Okay, so these two pathologic changes are going to happen in these small penetrating vessels. Okay, and these microaneurysms are also known as Charcot-Bouchard aneurysms. They're known as Charcot-Bouchard aneurysms. Okay, this is an important MCQ question. Okay, so there are four classical areas where you see hypertensive bleed. So number one is putamen. Putamen is the most common site of hypertensive bleed. Then you have the thalamus, the pons, and the cerebellum. Okay, so these four you have to remember, very, very important. They are common or classical sites of hypertensive bleed. Okay, now coming to the clinical features. So you have an abrupt or acute focal neurological deficit that progresses over 30 to 90 minutes. Okay, so it's the onset is going to be acute and it progresses very fast. An exception to this is IC bleed that is due to coagulopathy. So normally in coagulopathy, the progression is going to happen slowly and for a longer time. Okay, 24 to 48 hours in coagulopathy. Whereas in hypertensive ICH, the progression is very fast. In 30 to 90 minutes, the progression occurs. Seizures are uncommon. Okay, this is very, very important. Seizures are not very common in hemorrhage. Okay, only 10% of the cases are going to have seizures. Okay, and then you can have a drop in consciousness. Patient will have features of raised ICT like headache and vomiting. Okay, so these are the general clinical features of IC bleed. Now coming to the clinical features for specific areas involved. So as I told you, putamen is the most common site of hypertensive IC bleed. So since the internal capsule is just nearby to the putamen, you will have features of contralateral hemiparesis. So you will have contralateral hemiparesis, and along that you are going to have deviation of the eyes away from the paralyzed side. Okay, so each site of involvement is going to have very specific ocular findings. You should remember it for the exam. Okay, so in putamen you are going to have contralateral hemiparesis and deviation of the eyes away from the paralyzed side. Okay, next coming to the thalamus. So thalamus is also nearby to the internal capsule. So you're going to have contralateral hemiparesis along with hemianesthesia. You're going to have contralateral hemianesthesia that involves all the sensory modalities. Okay, and depending whether the dominant or non-dominant thalamus is involved, okay, you're going to have aphasia with preserved verbal repetition in dominant side thalamic involvement, and constructional apraxia and mutism in the non-dominant thalamic involvement. Okay, and the classical ocular finding over here is you're going to have deviation of the eyes downwards and inwards, and the pupils are going to be unequal and not reacting to light. Okay, so this is a very, very important MCQ question. Okay, what's going to happen? The ocular findings in thalamic hemorrhage. And you can also have visual field defects. You can have a homonymous visual field defect. And chronically, the patient can end up having chronic contralateral pain syndrome. This is known as Dejerin-Rossi syndrome. This is a very, very important MCQ. Now coming to PONS. Okay, so Pontine hemorrhage is a very, very bad prognosis. Okay, it's going to happen. You're going to have an abrupt onset of deep coma and quadriplegia within a very few minutes. Rapidly, it's going to happen. So you're going to have a deep coma, quadriplegia with bilateral corticospinal tract signs. You're going to have decerebrate rigidity, and classically, you're going to have pinpoint pupils that are reactive to light. Okay, that are reactive to light, and loss of the oculocephalic reflex or loss of Dalsey movements. Next, you're going to have hyperpnea, severe hypertension, and hyperhidrosis. Okay, so actually severe hypertension is going to happen in most of the IC bleeds. Okay, this is known as reactive hypertension. So that's why when you see compared to ischemic stroke, the presenting blood pressure in hemorrhagic stroke will always be higher. This is because of reactive hypertension. Okay, and in case the pons is involved bilaterally, especially the ventral pons is going to be involved. Okay, the patient might go in for a locked-in state. Okay, now coming to the cerebellum. Okay, so cerebellum is a very important part in hemorrhage because this is one of the IC sites of IC bleed where the treatment is predominantly neurosurgical. Okay, neurosurgical, and plus compared to supratentorial bleeds, cerebellar bleeds, remember that posterior fossa is a very small place. So even a minimal amount of cerebral edema, you're going to have brainstem compression and the patient is going to die. Okay, so it's important to act very soon in posterior fossa bleeds or mainly cerebellar bleeds. Okay, so the patient is going to have an occipital headache with severe vomiting, ataxia and vertigo, and you're going to have deviation of the eyes to the opposite side with an ipsilateral sixth nerve palsy. Okay, and as I just spoke about right now, patients are prone to brainstem compression because the posterior fossa is very small. Okay, and patient can go for hydrocephalus. And always remember, cerebellar bleed is something which is importantly more surgically treated rather than medically treated. Okay, now coming to cerebral amyloidangiopathy. Okay, this, as I discussed earlier, it's seen in elderly patients and it is the most common cause of lobar hemorrhage in the elderly. Okay, so cerebral amyloidangiopathy is going to present as lobar hemorrhage. So basically what happens is there is amyloid deposition in the blood vessels. Okay, and how the patient is going to present with multiple microbleeds in the cortex which accumulates over several months to years. Okay, multiple microbleeds. Okay, E4 and E2 variants of apolipoprotein E gene are going to increase the risk of lobar hemorrhage due to cerebral amyloid angiopathy. And remember, always you should avoid anticoagulants in these patients. Okay, you should avoid anticoagulants in these patients. Now coming to the two important sympathomimetic drugs, cocaine and methamphetamine. Remember, these drugs are going to cause IC bleed in young patients. They're going to cause IC bleed in young patients. They can cause intraparenchymal hemorrhage. They can cause ischemic stroke. They can also cause subarachnoid hemorrhage. But remember, the most common plane of IC bleed in these patients is going to be intraparenchymal. That's an MCQ question. Okay. Now coming to head injury. So head injury can involve any site. Okay. It can be intraparenchymal. It can be subarachnoid hemorrhage, extradural hemorrhage, subdural hemorrhage. And if it's going to be intraparenchymal, remember that the temporal lobes in the inferior frontal lobes are commonly involved. Now coming to metastatic tumors. Okay, so which malignancies will cause hemorrhagic metastatic lesions are choriocarcinoma, renal cell carcinoma, malignant melanoma, bronchogenic carcinoma, thyroid carcinoma, and atrial myxoma. And these are commonly going to present as a lobar hemorrhage. Now coming to anticoagulant therapy. Okay, so anticoagulant therapy can present as lobar hemorrhage or subdural hemorrhage. And remember, unlike hypertensive IC bleed, here the hematoma expansion, the progression is going to be slower and for a prolonged period of time. Okay, the hematoma expansion occurs over 24 to 48 hours. As you know, in hypertensive bleed, the progression is over 30 to 90 minutes. It's very fast. Whereas in anticoagulant therapy, hematoma expansion is going to occur over a longer period of time. Okay, now how we are going to diagnose intraparenchymal hemorrhage? Okay, so we're going to take CBC, you're going to have a non-specific transient leukocytosis. You're going to take PT, APTT, INR to check for any coagulopathy. And the investigation of choice is going to be non-contrast CT brain. Okay, very, very important MCQ. The problem with non-contrast CT brain is it might not visualize some small bleeds in the posterior fossa. So if you're doubting those, you can go for an MRI. So MRI will be useful in this scenario, but otherwise the investigation of choice is CT only. Okay, so you can take an MRI, CT angio, and X-ray angio when the patient, you're not sure about the cause of ICH. You're not sure about the cause of ICH, you can go for these investigations. And in CT angiography, you have a very, very important sign that is known as spot sign. So basically, you have an hematoma, and within the hematoma, you have areas of enhancement. Okay, you have areas of enhancement. Okay, this is known as spot sign. This represents ongoing bleeding. This represents ongoing bleeding and hematoma expansion. This is a very, very important MCQ question. Very, very important MCQ question. Okay, now coming to the treatment. Before we go to the treatment, there are two important scoring systems. You just know the name, it's enough. One is ICH score and one is Funk score. They basically to prognosticate. They basically to prognosticate the patient. Okay, so ICH score, just remember the components: age, hematoma volume, whether the presence or absence of intraventricular hemorrhage, whether the bleed is infratentorial or supratentorial, and the Glasgow Coma Scale. Okay, it has a total score of 6. These two scoring systems, just know the name. Okay, now coming to the treatment proper, obviously airway, breathing, circulation. After you're done with that, BP management. Okay, so BP management, remember for the exam purpose, a target BP of less than 140 is 140. A target systolic BP of less than 140 is what you have to achieve, and the drugs you can use are nicardipine, labetalol, and esmolol. Okay, and the trial for this is also known as Interact 2 trial. Interact 2 trial. Obviously, after this, we had attached 2 trial, which said that the target BP need not be 140, less than 140. But for the exam purpose, remember that less than 140 is the target blood pressure you have to achieve. Okay, now coming to reversing coagulopathy. Okay, reversing coagulopathy depends upon what anticoagulant the patient is on. So, if the patient was on a vitamin K antagonist like warfarin, the blood product of choice that you're going to give is prothrombin complex concentrate. Okay, remember it is not FFP. The blood product of choice is prothrombin complex concentrate. Only if PCC is not available, you can go for FFP. Okay, this is very, very important MCQ, and obviously you're going to give vitamin K. Okay, in case the patient was on any novel anticoagulants like dabigatran, here the drug of choice is going to be idracizumab. You can give 2 doses. If the patient was on factor 10A inhibitors, here also the blood product of choice is prothrombin complex concentrate. And when do you transfuse platelets? Only if the platelet count is less than 50,000. Otherwise, there is no role of platelet transfusion. Now, managing raised intracranial pressure, so head end elevation. Okay, IV mannitol or IV hypertonic saline, hyperventilation to drive out the CO2, but remember this is used only in the acute scenario. You can't use it in the long run, only in the acute scenario. And remember, there is no role of steroids. Very, very important, no role of steroids in reducing the ICP over here. And your target cerebral perfusion pressure is 50 to 70. So how do you calculate cerebral perfusion pressure? It is mean arterial blood pressure minus intracranial pressure. Okay, this formula is very, very important for the examination. And in case the patient is still having a raised ICP, GCS is falling, patient is developing hydrocephalus, in those scenarios you can consider surgery. Okay, but remember that generally, okay, if you take supratentorial bleeds, there is no major role of surgery. There is no major role of surgery. Okay, and this is based on the Stitch study. This is based on the Stitch study. Just know the name. Okay, so for supratentorial bleeds, there is no role of surgery. But however, for cerebellar hemorrhage, the main treatment is going to be surgery. So whenever you have a cerebellar hemorrhage, you have to call the neurosurgeon to assess the patient and for further management, because cerebellar hemorrhage, like I told you, the posterior fossa is very small place. Even a small amount of cerebral edema, you're going to get brainstem compression in the patient. You're going to lose the patient. So when do you operate is, if the bleed is more than 3 centimeters, you have to go for surgery. If it's a small bleed less than 1 centimeter, you can medically manage. If the patient has 1 to 3 centimeter size bleed, you have to observe for warning signs. See whether the patient's ICP is raising, whether the patient's GCS is dropping, whether the patient is going to develop any hydrocephalus. If the patient is going to develop any of that, you can go for surgery. Okay, so this is about the intraparenchymal hemorrhage. I think I've covered most of the important points. Thank you.